Good morning everybody and welcome to Health Talk. I am your host Dr. Niru Prasad with my background in pediatrics and emergency medicine affiliated with Henry Ford Health System, St. Joe, Oakland and Beaumont. The theme of our Health Talk today is lung cancer. Our guest speaker today is Dr. Mohammad Muhsin Chisti, who has been previously here to my show a couple of times before. He is the medical director of research at Karmanos, and he is going to highlight us some issues and some questions, some issues regarding the lung cancer. So, good morning. Can you please, before give your introduction to our viewers? I know you have been here so many times and you have done a wonderful job before, very well appreciated by our viewers.
Good morning, viewers, and good morning, everybody. It's a great pleasure for me to come back to this show, and I like coming here and talking about different things. So, I'm an oncologist by practice. I'm an assistant professor in Michigan State, and I teach in a couple of medical schools, and I also work with Karmanos Cancer Institute, and as my role is medical director in research, establishing clinical trials in the community.
So that's very good. Next time you will let us know about what are the clinical trials that are being done. So what is lung cancer?
So I'll try to make it simple and easy and start with the basics. Basically, when we define cancer, cancer is a clone, it's proliferation. Right. It's like one cell going crazy, either due to genetic modification or due to some toxin or some other cause that leads this cell to become to form a clone of cells, to keep on multiplying without any reason and take up the resources of the body and finally become like a mass. And similarly in lung, there are many types that can happen, and these masses occur in different parts of the lung and cause and then they metastasize and go to different parts of the body.
So yeah, before we talked about the clonal antibodies and all those before, but today we are mainly concentrating about focusing it about the lungs type, and then the impact. What are the impact and the survival?
Lung cancer, So
first, let us talk about lung cancer. Shortly, how we make the diagnosis. I know everybody knows about smoking, COPD, but let's make it a little simple for our viewers.
So lung cancer has a huge impact on the community. 1 in 7 smokers is going to develop lung cancer.
That's 1 in 7?
Yeah, it's kind of very high percentage, especially in what I have seen in living very close to the Pontiac area. There's a huge smoking population, and we see quite a lot of lung cancers because of that reason. And also the other thing is there are almost like 18 deaths per hour happening because of lung cancer.
It's a huge impact. That's a very high number.
And at the same time, lung cancer kills more people than breast, colon, prostate summed up together.
All together.
Yeah, and unfortunately, we don't get a lot of funding in lung cancer because as we have in breast cancer, and they say just because women talk more. But definitely this is a big area of concern. And then we talk about survival rates in lung cancer. Survival rates in lung cancer have not dramatically improved. When we look at different types of different types of cancers, lung cancer, we have not had a significant progress. Now with new improvements in the modalities of treatment, maybe we will see improvement down the road. But if you look at the graph, it doesn't show a huge progress as compared to other cancers like colorectal and breast and so on and so forth.
Breast and the colorectal, they have a very good prognosis now, as we all know. But not much for lung cancer.
So traditionally, when we view as lung cancer, we look at the type of tissue that from where the cancer started. So it could be broadly divided into a small cell lung cancer type or a non-small cell. So small cell lung cancer is 15%, roughly 14-15% of the lung cancers, and they are mainly from the what we call as neuroendocrine cells that go crazy and form a mass, mostly in the central part of the lung. And they are very aggressive cancers. They are very difficult to treat, and most of the times they, by the time we diagnose them, they are already stage 4. Yeah.
Is there a high metastasis rate also?
Small cell lung cancer has a very high metastatic rate. It really loves to go to the brain and the liver, and it's metastasizes pretty fast. The other type, non-small cell lung cancer, so traditionally we know it could be either a gland cancer or a lining cancer. The gland cancer is more like the adenocarcinoma, and the lining is the squamous cell carcinoma.
So when you know, I have done some fellowship in pathology, hematology, and I have reviewed those slides, but when you said about the membrane, is it like it starts from the outside of the cell and the adeno inside with the glands?
Right. So, well, when we go to the background, how the lung is made, you know, what are the tissues present there.
Alveoli and the
so the
lining.
glands basically form the gland type of cancer known as adenocarcinoma, which is very common.
Yeah.
And the other type is the lining of the lung, which covers it, which mainly is the squamous cells, so squamous cell carcinoma. So traditionally, that's how we view it, either the small cell or a non-small cell. In non-small cell, you have a gland or adenocarcinoma or a squamous cell carcinoma.
So the classification has become simple now.
Right. And then you can, the other type, sometimes the other rare types, there could be lymphomas in the lung, there could be mesothelioma, which is related to asbestos.
That is for occupational.
Then we go to the causes. So as we mentioned, smoking.
What are the causes?
Yeah, smoking is the really huge cause.
Number one.
Number one cause that that we have associated with lung cancer. As we mentioned, 1 in 7 smokers can develop lung cancer. And then asbestos, radon gas has been, which is present in the basements or in the mining, mining
the miners,
areas.
that's the miners.
Then polycyclic aromatic carbons, and then nickel, and these all have been associated with lung cancer. There are also genetic causes like Livermany syndrome and others that, and also people that have long-standing conditions, they can develop
like
lung
long-standing. When you said that, are we talking about the COPD?
It's more smoking than COPD that causes lung cancer. But there are like people that have alpha-1 antitrypsin deficiencies, genetic, genetic changes that lead to cancer, not only in lung but in other parts of the
other parts. So that leads to the next question. How do we make the diagnosis?
Right. When we talk about how do we diagnose lung cancer, first and foremostly,
I see the patient, then I suspect, then I send it to your office. You know, we give a referral to the oncologist. What do they expect once they go to your office?
So initially, I would try to touch a little bit about screening here. Most of the cancers where we have achieved quite a lot is by diagnosing the cancers very early in their stage, so that we can cure those people. In lung cancer, we have been really behind because there is not a tumor marker we could check from blood. There's not like a simple scan like a mammogram in breast, which we could use in lung. So a lot of trials have been done, a lot of studies have been done. So what they found is people that are smokers have very high risk of developing lung cancer. At least screening CAT scans should be offered to them. So right now the guidelines say,
these are the guidelines for diagnosis.
Right now the guidelines say patients that are heavy smokers, at least like 30 pack years, which is like smoking for 30 years or 1 pack a cigarette per day, should get screened if they are above 54 to age of 74. So 55 to 74 years of age, they should get screening. And the screening is done by a CAT scan. It's a low-dose CAT scan, and if they find a lung nodule, then they go for a biopsy, and depending on how big it is, or sometimes we can just put those people on surveillance and repeat a a scan
Repeat the
in a
scan.
year and see if that nodule is growing, or in 6 months if nodule is big enough, and do a PET scan, then a biopsy to see if it's a cancer. We take it out or we treat it with radiation.
Sure, yeah. So,
So other
MRI of the brain just to rule out that
Yeah.
there is no metastasis, or is it routinely being done?
So regarding the diagnosis, the modalities that we use is a CAT scan of chest, abdomen, pelvis in a patient of diagnosed lung cancer that we call as like a staging workup. So because these are the common areas where the lung cancer can go, especially as I mentioned, small cell lung cancer goes to the liver, and then it also goes to the brain. So MRI of the brain becomes very important.
Yeah,
Because if
MRI.
somebody has brain metastases, like the cancer has already gone into the brain, the first thing you want to make it sure is the brain is treated first. The brain
Right,
takes
yeah.
priority over everything
Sure.
else. So you want to first treat the cancer in the brain if
In
it
the
has
brain.
gone there.
So that is by radiation
Right.
mostly,
Right, mostly radiation.
and chemotherapy, right?
Chemotherapy doesn't have a huge role in there, but mainly it's radiation.
It's the radiation.
Then the other modalities that we use is the ultrasound with the bronchoscope. So there's a thing known as endoscopic bronchoscopic ultrasound. So,
Bronchoscopy,
yeah.
okay.
So that's that is the pulmonary or the interventional guys. They put the scope in, get the biopsies of the lymph nodes. That's important for staging.
Okay.
So that helps us to understand what stage it is. Is it a stage 1, stage 2, stage 3? I'll come to that later. And then the other modality is the PET scan. So PET scan is basically a scan that works on glucose, not a dye, but a glucose. So since we know the cancer cells are fast growing cells, they use a lot of glucose. So that's how they came up with this brilliant idea. So we give radioactive glucose, then take a image. So wherever you find the hot spots, what we call as SUV, units. So so we consider that as the metastatic spot. That is the spot where the cancer
So
has
that
spread.
is very interesting to know that they are glucose.
Yeah, it's
they
based on
pick up
glucose uptake,
glucose
because
uptake.
cancer cells are fast growing cells and they take a lot of glucose.
Right.
So these are the modalities that we use for staging the cancer. So for staging the lung cancer. So after we have staged, so then we come to the next step.
Okay,
Yeah.
so after we have staging, different kinds of the modalities.
Yeah.
So then we are talking about the treatment.
Right.
of the-
So once we have staged, depending on the stage, what we find, the treatment is accordingly given. Let's talk about non-small cell stage 1 cancer. So stage
Yeah.
1 cancer is usually a single mass that is only in one part of the lung, has not gone anywhere else in the body. So it's a small cancer, only like a couple of centimeters big. We have criteria known as
stage.
AJCC staging criteria. That's what we use. That's all the oncologists and cancer people use. So if there is like a small mass, like a couple of centimeters big, and there's nothing else on the PET scan, everything else is clean. So those cancers are treated with surgery.
Okay.
So there are
Because
people,
they are localized, so that the
Right.
surgeons can take them out.
Exactly. That gives taking the cancer out of the body is the best treatment for cancer. That's what we
Right,
do.
yeah.
So that's the best modality.
Stage 1 surgical resection.
Right. But there are people that have bad comorbid conditions, that have bad COPD.
Right,
they
aging
have,
COPD.
Yeah, they are aged. Their performance score is not greatest. For those, we do stereotactic radiation, SRS, or the gamma knife for that stage 1 cancers, for that particular cancer. So for them, you can, and to be honest with you, this is such a good modality that it gives almost like 88% same.
Is that so?
Yeah.
Yeah, it's a
kind
good
of success rate.
modalities because it just radiates them.
Right, it just kills the cancer in the place.
Kills the
Yeah, and it's like 88% success rate as compared to surgery. So it's a very good option for them.
So now we are talking about the treatment.
Yeah,
And
then
how about, before we used to give so much of chemotherapy and all the side effects, you see them.
right.
So less chemotherapy is good, right?
Right, I'll come
Not
to that
much side
in
effects,
stage.
yeah.
So then we come to the stage 2 cancer. Stage 2 are bigger tumors which are occupying bigger spaces in the lung, but still lymph nodes are not involved. So those are the stage 2 cancers.
Okay.
For them also, surgery is the best modality. So you still want them to get surgically resected. And now after they get surgically resected, maybe the lobe or the whole lung is removed, After that, we add chemotherapy to those stage 2
So those
lung
are
cancer.
stage 2.
Yeah,
Okay.
we call it adjuvant. Adjuvant means like add-on therapy that will make it
Add-on.
sure that the cancer does not come back in the person's life again.
Okay.
So the chemotherapies that we usually use for those people are platinum-based, like cisplatinum, which is an age-old agent which has been there for many 20, 30 years. A great drug that has improved overall survival in people with limited stage cancers.
So it's very interesting to know how
Yeah.
the treatment by radiation depends upon
Right.
all these different modalities, and that
Right.
platinum is
Right.
has been there
It's
for
the backbone. It's the backbone.
Is the backbone for the cancer.
Then we come to a stage 3 cancer. It's a very tricky situation. Stage 3 cancers lung cancers are those that the cancer has already spread to the lymph nodes or the mediastinum or the chest, but still not present in any part of the body. So it's still a localized cancer.
Right.
So a lot of trials have been done, and the best data that we get is if we treat this cancer with concurrent chemotherapy and radiation, that gives the best survival for the patient. So there are two ways we treat it, stage 3A and 3B. For a stage 3A cancer, which is a cancer that is locally involved but still can be cured and can be surgically resected, we give neoadjuvant. Neoadjuvant means before surgery. So before surgery, we give radiation and chemo with platinum.
To shrink it, right?
To shrink it down. And then the thoracic surgeon comes. It's like a multidisciplinary approach. We discuss these cases in the tumor board. And then the thoracic surgeon comes and then removes this tumor.
So this is the survival rate of this.
Yeah, so when we talk about, so why do we do staging? Staging is because of we want to know the survival
right,
rates.
and
so stage 1 lung cancers have 70% survival. So 70 people out of 100 will survive 5 years. That's a great survival
It's
rate.
a great,
Stage 2, it's half of them will survive.
Right.
Stage 3, only quarter of the people will survive. Those are the people that we are talking.
Right.
And stage 3 and stage 4, unfortunately,
not
hardly
much.
anybody makes it to 5 years. But this is old data. This is all before the new modalities came. I'll talk about the new modalities after this. So stage 3B, so going back to the treatment of the stage 3, those are treated with chemotherapy and radiation. Then they are not the surgical candidates. The cancer is in such a bad shape that you cannot remove a lung, you cannot remove it surgically.
Right.
So what you do is, you do definitive radiation. So you give more radiation followed by more chemo so that the cancer is killed in the place rather than taking it out. The survival is still, as you saw, is not that great.
Not that good. So now we'll talk about the targeted therapy that you already we did that in previous.
Right. So now coming to the stage 4 cancers, that is that's the area where we have really changed paradigm of treatments in the last few years. We still talk about chemotherapy, we still talk about targeted, but the new thing that has come is the immune therapy, which I'll touch base on. So going first with the chemotherapy. So for stage 4 lung cancers, we know that the cancer has gone elsewhere from the lung, it has gone to other parts of the body. So we want to give a drug that goes through the veins, goes to all parts of the body and kills the cancer cells at all the places. So if it has gone to the bone, we want to give site-specific radiation to those spots which are causing pain. If it has gone to the brain, we want to do the gamma knife to that, or we want to even surgically resect that one tumor if that has developed in the brain. If it's many, then whole brain radiation.
But if it is one, that it can be resected.
Yeah, you can resect it. Neurosurgery does a great job and they can remove the tumor. But if it is kind of spread throughout the brain, then we give whole brain radiation. It still improves survival. Without doing anything, if the cancer is in the brain, average median survival is a couple of months at the most.
So stage 1, and then lastly we are doing the immune therapy.
Right. So now, before going to immune therapy, so chemotherapy that we use in lung is again the platinum base that I was talking about. Cisplatinum and carboplatinum are the main agents. And in the the gland cancers, we use a drug known as pemetrexed or Alimta. And then also there are other drugs that we have been using. Then going to the targeted therapy. Targeted therapy has also changed the paradigm of treatment quite a bit. So one of the important targeted therapy I want to talk about is bevacizumab or Avastin. So to make it very simple to understand, the tumor secretes vascular endothelial growth factor receptor, which is a receptor, which is an antigen secreted by tumor that increases the growth of blood supply around the tumor. So tumor kind of is an evolutionarily very evolved cell line that takes care of the blood supply and everything. So what we have learned that if you give a drug that will cut down the blood supply of the tumor, you get a very good response. You kill the cancer. So Avastin or bevacizumab or ramucirumab or the new other drugs that are coming in this area do exactly the same thing. So they cut the blood supply to the tumor.
How is this drug administered?
So this is an IV drug given every 3 weeks. So the other drug that that we use is ramucirumab, which is kind of the similar drug, you know. And then the other target that we use in lung is the epidermal growth factor. Epidermal growth factor is another antigen that is expressed by lung cancer cells, mainly adenocarcinomas and also squamous cells. So what we do is basically we have two types of drugs. One is the antibody like necitumumab, which is which kind of fits on the surface of the cancer cells and then kills the cancer cell. The other is the tyrosine kinase inhibitor, which are pills, which have shown tremendous success in people that have EGFR mutations, like erlotinib is one, ruxolitinib is another, afatinib. So there are kind of lot of pills that we use in targeted therapy in people that have those mutations, that harbor those mutations. And there is a special type of mutation known as ALK or ROS1 mutation, and those people that have that mutation benefit from pills like alectinib, crizotinib, ceritinib. And I have a patient who is on it for like now 7 years, metastatic stage 4 lung cancer.
Is that so?
Yeah.
He should be written up then.
Well, it's becoming common. That's why I'm telling you the survival in lung cancer has dramatically changed now with these targeted agents.
I know there has been so much recent advances with this chemotherapy and the treatment, and hard for me to catch up with them.
So when we get a patient who has lung cancer stage 4, we take the tissue from the biopsy and do a thing known as next generation sequencing. So what that does is that runs a panel of all those genotypes, all those genes and the molecular markers, and then we compare that which drugs would be effective for that individual. Does this patient have EGFR mutation? No chemo needed, just give Tarceva, the pill. If ALK, only crizotinib or alectinib drug, not.
So it depends upon what they have.
It's like exactly like infectious disease specialist does, checks the infection for the antibiotics, the sensitivity. That's how we are kind of doing it. We are tailoring the medication as per the cancer. So depending on what type of mutation we find, we do it. So this is showing like, you know, the targeted therapies that are available for different types, like BRAF mutation, vemurafenib, MET mutation, you know, crizotinib, so on and so forth. Some of them are still in the trials, and they will be, you know, becoming standard of care down the road. But right now, you know, the ones that are available, I talked about that.
Yeah, so that's very good to know, because it would be interesting to know the clinical trials issue also. So that's I'm very happy that you were able to come to my show.
This is the immune therapy. I will briefly talk about this. This is creating your own body to fight the cancer by you know, creating a strong immune system. So the way it is done is the cell produces antigens. They are taken by the antigen receptor cells, and then they create the T cells, which are the immune cells in our body. And those T cells kill the cancer.
Those T cells,
it's the drug that we are...
therapy, it is fascinating,
It's very fascinating. It's a PD-1, PD-L1. So recently there was a trial, just was published a few days ago, pembrolizumab they say is even more efficacious than chemotherapy. So I foresee shortly that there will be a day that we will
down
be
the road, with the treatment.
yeah,
it will
removing
be all,
chemotherapy altogether and giving them the immune therapy upfront.
Upfront, which is very good. Thank you so much for coming to my show today, Mohammad. And I'd like to thank our viewers, our producers, camera crews for helping me prepare this beautiful tape, interesting, with Dr. Mohammad Chisti, who is the medical director now of research at Karmanos and also an oncologist affiliated with different hospitals in Oakland. Thank you again, and have a wonderful
Thank you. It has been a pleasure to come over here.
Thank you.
Thank you.
Yeah.